If you're over 60 and you're facing surgery, there's something your anesthesiologist already knows about your body that you probably don't, something that changes how every drug we give you behaves, something that makes your risk profile completely different from a younger patient in the same operating room. And in the next few minutes, I'm going to tell you exactly what that is, clearly, directly, because most patients never hear this before they go under. I'm Dr. Michael Kent. I've been an anesthesiologist for 15 years, and I need to say something that most of my colleagues don't say out loud. After 60, anesthesia becomes a different procedure. Not a harder version of the same thing, a fundamentally different thing. The same dose that puts a healthy 40-year-old safely to sleep can push a 70-year-old into dangerous territory. And the reason why, the biology behind it, that's what nobody explains to you before you sign the consent form. But before I tell you why age makes anesthesia dangerous, you need to understand what's already changed inside your brain. Because this isn't about being sick. This isn't about being weak. This is about what normal aging does to the organ that anesthesia targets first. And what's happening inside your skull right now is something most patients have no idea about until something goes wrong. Here's what nobody tells you. Starting around age 60, your brain physically shrinks. Not because you're sick, not because something's wrong, because it's normal aging. Your brain loses about 0.5% of its volume every year after 60. That means by 70, your brain is roughly 5% smaller than it was at 60. By 80, it's 10% smaller. This isn't disease, this is biology. But inside an operating room, it changes everything. It's not just size, the chemistry changes. Your brain produces less of the neurotransmitters that regulate consciousness, alertness, and memory. The receptors that anesthetic drugs bind to become more sensitive, and the blood-brain barrier, the protective layer between your bloodstream and your brain, becomes more permeable with age, more porous. Anesthetic molecules cross it faster, penetrate deeper, and reach concentrations in your brain tissue that would never happen in a younger patient at the same dose. Now you're probably thinking, okay, so they just give me less anesthesia. Problem solved, and you'd be half right. We do give you less, sometimes 40 to 50% less than we'd give a 30-year-old. But here's where it gets complicated. The margin between enough anesthesia and too much becomes incredibly narrow after 60. We're not working with a comfortable range anymore. We're threading a needle, and threading a needle inside a moving surgical environment with a body that doesn't respond predictably, and that's where things go wrong. But that's just the beginning. What happens to the drugs themselves once they're inside your body, that's where the real danger lives. Every drug we give you has to be broken down and eliminated. Two organs do that work. Your liver metabolizes the drugs, breaking them into inactive compounds. Your kidneys filter them out of your bloodstream and excrete them in your urine. Here's the problem. After 60, both organs slow down. And the consequences of that slowdown are something most patients never consider. Your liver function decreases by about 1% per year after 60. Your kidney function decreases even faster, sometimes 1 to 2% per year. By 70, your kidneys might be functioning at only 60 to 70% of what they did at 30. That means anesthetic drugs stay in your system longer, much longer. When we give propofol, the drug we use to put you to sleep, a 30-year-old clears half of it in about 40 minutes. A 70-year-old, it might take 90 minutes or longer, more than double. And during every single one of those extra minutes, that drug is still working, still suppressing your breathing, still lowering your blood pressure, still sitting inside your brain. You are not safe just because the surgery ended. The drug is still there. And here's what makes it worse. When drugs stay in your system longer, they accumulate. Each dose during a long surgery builds on what's already there. What starts as a calculated, appropriate amount becomes an effective overdose over 2 or 3 hours. Not because we made an error, because your aging biology changed the math while you were on the table. This is why anesthesia after 60 isn't just about giving you less. It's about constant vigilance, constant adjustment, constant recalculation in real time. What was the right dose 10 minutes ago may be dangerous right now, but there's something that keeps me more alert than drug accumulation, something I think about every single time I have a patient over 60 on my table. And it involves the one organ nobody considers when they're preparing for surgery. Your lungs. Even if you've never smoked, even if you exercise regularly, even if you feel completely healthy walking into that hospital, your lungs have changed, and those changes create a specific serious risk under anesthesia that most patients never know exists until they're already in recovery dealing with it. The lung tissue loses elasticity, it becomes stiffer, less able to expand and contract efficiently. The alveoli, those tiny air sacs where oxygen crosses into your bloodstream, become less efficient at gas exchange, the breathing muscles weaken, and the brainstem's drive to breathe, that automatic signal telling your body to inhale right now, becomes less responsive to rising carbon dioxide after 60. In a younger person, this feedback loop is tight and fast. Carbon dioxide climbs slightly, the brainstem fires, breathing increases. But after 60, that loop slows. Your body tolerates higher carbon dioxide levels before triggering a response. During anesthesia, we take over breathing with a ventilator. That's the plan. But the problem comes at emergence when we try to hand breathing back to you. In a younger patient, that transition is smooth. The drive returns, breathing deepens, oxygen levels hold. In an older patient, it's a fight. The drive is slow to come back, breathing stays shallow, oxygen drops, carbon dioxide climbs, and we're managing your airway long past the point where we should have been able to step back. I've had patients in their 70s and 80s who needed an extra hour in recovery just to breathe adequately on their own, not because the surgery went badly, not because something went wrong, just because their aging lungs couldn't make that transition the way a younger person's would. And that's still not the most dangerous part. What I'm about to tell you about your cardiovascular system, this is where age-related anesthesia complications become genuinely life-threatening. Anesthesia lowers your blood pressure, always. That is not a side effect. It is a direct pharmacological consequence. Anesthetic agents relax blood vessel walls and reduce how forcefully your heart pumps. In a young, healthy patient, the body absorbs that drop and compensates. In a patient over 60, that ability to compensate is often gone. Your arteries have lost flexibility. They can't adjust to pressure changes the way they used to. Your heart muscle is slightly weaker. The electrical system controlling your heartbeat is less stable, more prone to arrhythmia under surgical stress. So when anesthesia drops your blood pressure, your body struggles to pull it back up. And low blood pressure that persists even for minutes, is directly dangerous to the three organs that cannot survive without adequate blood flow: your brain, your heart, and your kidneys. We see this in the outcomes data. Older surgical patients have meaningfully higher rates of post-operative stroke, cardiac events, and acute kidney injury than younger patients. A significant portion of those complications trace directly back to periods of inadequate blood pressure during the procedure. I've had patients in their early 80s where a routine procedure became an extended cardiovascular emergency. Blood pressure dropped and refused to respond. Fluids, vasopressors, constant adjustments. Everything turned out fine, but only because of aggressive management and a margin of safety that was thinner than it should have been. But even if we hold your blood pressure perfectly, even if breathing recovery goes exactly as planned, even if every single number stays where it should for the entire procedure, there is still one more thing that happens after 60, something that doesn't show up in the operating room, something that follows you home. And this is the part most patients find the most disturbing, because it doesn't affect your body, it affects your mind. This is called post-operative cognitive dysfunction, POCD, and it is far more common in patients over 60 than anyone in medicine openly admits. Studies show that up to 40% of patients over 60 experience measurable cognitive impairment after surgery and anesthesia. 40%, nearly 1 in 2. And yet this is almost never part of the preoperative conversation. Patients consent to surgery without knowing it exists. What does it look like? Confusion and disorientation in the days after surgery, memory gaps, forgetting conversations that happened hours ago, names of people you know well, appointments you made, difficulty concentrating, trouble following instructions that would normally feel simple, a mental fog that doesn't lift the way you expected after you got home and rested. For some patients, it resolves in days. For others, it takes weeks. For a significant number, it persists for months. And for a subset, it never fully resolves. There is growing clinical evidence that anesthesia exposure in older adults can accelerate cognitive aging, that it can, in vulnerable patients, push someone closer to dementia faster than they would have gotten there otherwise. The leading theory involves neuroinflammation, a cascade of inflammatory activity inside the brain triggered by the combined stress of surgery and deep anesthetic suppression. We know that patients who spend more time in the deepest anesthetic states have significantly higher rates of POCD. The longer your brain sits in that profoundly suppressed state, the higher your risk. This is why modern anesthesia in older patients focuses on the lightest effective level. We use brain activity monitors. We avoid going deeper than necessary. We use shorter acting drugs when surgery allows it. We are actively trying to protect your brain while the procedure does what it has to do. But we cannot eliminate this risk, and you deserve to know, before you sign anything, that there is a real chance your mind won't feel like yours for a while after surgery. Maybe a short while, maybe a long while. That is information you have a right to before you consent. Now, here is the thing that ties all of this together: the shrinking brain, the slow drug clearance, the weakened lungs, the fragile cardiovascular system, the cognitive risk. These are not separate problems running in parallel. They compound each other. Each one amplifies the others. Together, they create a situation where anesthesia after 60 is exponentially more complex and more dangerous than it is in a younger patient. But here's what you've been waiting for, because everything I've told you so far is about anesthesia working too well. What I'm about to tell you is the exact opposite problem. Anesthesia can fail in older patients, not because we gave too little, because the aging brain becomes biologically unpredictable in ways no preoperative test can detect. Remember when I told you that your brain's receptors become more sensitive after 60? Here's what that doesn't tell you. In some older patients, specific receptor populations don't become more sensitive. They become resistant, dysfunctional. And when that happens, normal doses don't work. The patient doesn't achieve full unconsciousness, or they're unconscious but still responding to surgical stimulation, moving, heart rate climbing, blood pressure spiking. We call this anesthetic resistance. There is no test for it beforehand. We don't discover it until we're already in the case and the patient isn't responding the way they should. I've had patients in their 70s who needed double the calculated dose of propofol just to reach adequate unconsciousness. Double. And because their liver and kidneys cleared that massive dose slowly, it stayed in their system for hours. What should have been a 90-minute recovery stretched into 3 hours. Delayed breathing, unstable blood pressure, extended monitoring, all because their brain didn't respond the way it does in 95% of patients. And sometimes it goes the other direction entirely. Extreme sensitivity, where a dose calibrated to cause mild sedation produces deep unconsciousness and severe cardiovascular collapse. Blood pressure crashes. We're scrambling to support them while their body slowly processes a drug we gave in what should have been a careful conservative amount. Resistance in some, extreme sensitivity in others. No way to know which one you are until you're already under. That unpredictability, that's the deepest hidden danger of anesthesia after 60. The normal rules don't always apply. So here's what I need you to take away from everything I just told you. Anesthesia after 60 is riskier than it is for younger patients. Not catastrophically riskier, not a reason to avoid surgery you need, but measurably significantly riskier in ways that are real, documented, and demand a higher level of preparation, monitoring, and experience from everyone in that room. Your brain processes these drugs differently. Your body clears them more slowly. Your lungs take longer to recover. Your cardiovascular system has less room for error. And your mind may not feel sharp for weeks or months after you wake up. But here's the other side of that truth. We know all of this. Experienced anesthesia teams plan for every single one of these risks. We adjust doses, we monitor brain activity, we use shorter acting drugs, we wake you up more gradually, we watch you more closely in recovery. When it's done carefully by people who understand what 60 plus years does to the human body, it is still safe, just different, harder, more demanding, but manageable. What you can do right now before any surgery is talk to your anesthesiologist before you go in, not after. Before, tell them your concerns. Ask specifically how they'll adjust for your age. Ask whether brain monitoring will be used. Ask about their plan for emergence and recovery. Ask what cognitive changes you should watch for in the weeks after your procedure. And ask someone you trust to be with you after surgery and pay attention. Be informed, be specific. Be the patient who asks the questions most patients never ask, because this is your brain, your body, your life. Age changes anesthesia. The drugs behave differently. The risks are higher. The margin is narrower. But knowing this, understanding exactly what your body is facing before you walk into that operating room, that's how you go in prepared instead of blindsided. That's how you make sure the people responsible for you are paying attention to what actually matters. Share this with someone over 60 who has surgery ahead of them, because this is the conversation that should happen in every pre-op room in every hospital. And most of the time it doesn't. Everyone facing surgery deserves to know what they're actually walking into. Thanks for watching. I'll see you in the next one.